So next we have our keynote lecture, and it is my absolute pleasure to introduce our keynote speaker, Dr. Barbara Boyan. Barbara is professor in William H. and Alice T. Goodwin Chair in Biomedical Engineering and the Dean of the School of Engineering at Virginia Commonwealth University. And actually, several of your surgeons are here today, and they're representing your institution very well. She's also professor emeritus in the William H. Coulter School of Biomedical Engineering at Georgia Tech and Emory. And she was there as chairman for 10 years, and that's where I got to know Barbara. She's also a fellow of the American Association of the Advancement of Science, and she's been elected to the National Academy of Engineering and is a fellow of the World Congress, or of the World Congress of Biomaterials. To get all right. Yeah, I know. I could go on and on. She's also director of the Virginia branch of the Atlantic Pediatric Device Consortium, which she actually started when it was the Atlanta Pediatric Device Consortium. She has over 430 peer-reviewed articles, papers, reviews, and chapters, and 16 patents. It's my pleasure to present to you Dr. Barbara Boyan. Thanks.
Well, first I'd like to thank you so much for giving me this opportunity to talk about something that is really important to me, very close to my heart, and I don't get to talk about it often enough, so you have to let me wax poetic a little bit here. And the first thing I really want to talk to you about, and I think most of you understand all of this intuitively, but it really bears saying why it is so difficult to make new devices for kids. We're going to spend a little bit of time on why it's so difficult and on some of the solutions that we've used to overcome these difficulties, and I have moving quickly. I don't know how I did that. So these are some of the very basic reasons about why it's so hard to do, and not the least of which is the fact that children are growing continuously, and so many times the devices have to change to accommodate their changes in their immune system, the fact that the sizes have to be different, and the way that they are presented to the child needs to be different. But this is some stuff that we don't think about in a clinical environment or even really in a school of engineering. This is when it comes time to be commercialized and why we don't understand why every company isn't just jumping off the wall to get their hands on some of our ideas. There are very few standards that are present that the FDA or the International Standards Organization can rely on to have any idea as to whether what we've designed, what we've developed, what we want to make will be easy to pass through a regulatory pathway. And something that we often don't think about is the fact that many of these devices are not going to be used by surgeons. They're going to be used by the parents. And not all parents are equally educated to understand the fine print. And so they have to be designed in a way that they can be used in the settings that make the most sense. And parents are present in all of these settings. So how do we design even the space in which the device will be used so that it can be effective and safe? And the most important thing is that everything that we would want to do in a child, we need to test in an animal. But there are very few relevant animal models, and very few relevant animal models are being developed. And by that I mean the age of the animal. We can test a lot of things in male mice, but half of the population of children are not male mice, they're female mice. And we haven't even considered really what the differences that gender puts in. I just want to give you an example from my own work in my group to show you how important age is. This actually is a mouse model of a treatment for craniosynostosis that we developed at Georgia Tech. If we make a defect in the aged child that actually is going to be treated primarily in the United States for craniosynostosis, it resyностoses almost immediately. If a child is over 2 years of age, which is the way it is in most countries, these children, that defect never heals. So we have even to consider the culture, we need to consider how the material will be used, and we need to understand why things happen differently at different ages. Now, getting a device, if we can make it through the preclinical assessments, even to get it to the market from a commercial point of view, is not trivial. And this is where it becomes really more stressful for you as clinicians than it is for me as a basic scientist. The patient populations, we just heard, 10 very wonderful talks where the patient populations were typical. They were teensy. So it's really difficult to power these studies adequately, and therefore they have a hard time in the regulatory pathway. The market sizes are really small, and companies can't afford to make the investments that are necessary. And this is really important, and we don't talk about it enough. The US is totally litigious. Parents want a perfect outcome, and to develop a new device that might not be perfect at the start is really anathema in the American culture. And finally, this is something that I think many of us in this room recognize. Medical school conflict of interest policies are draconian. It is fine for a drug that gets developed and tested and the protocols are all worked out, but devices are developed in an iterative way. There's engineers involved, there's surgeons involved, and the company people involved, and all of those things are impossible. It's impossible to do without the this is a very high-tech environment here. So now I have to go down to the picture. All right, so I'm going to walk you through a problem that is one that we've worked our way through. I am an orthopedic type of researcher, so you're going to have to painfully listen to some bone stuff, but I won't make it too bad. I do want to remind you, when I talk to orthopedic surgeons, I have to remind them what is an osteoblast and what is an osteoclast, but I know you guys have got that covered, so we're not going to worry about that. We're just going to remind you what bones look like. Okay, so we have a problem, a biological problem that is very big and actually impacts research and surgery that you do, and that is the spine. The spine its structural properties, its mechanical properties, everything it does change from the time the fetus is first formed until the child becomes an adolescent and after growth stops. And so this is a very different process in the fetus than it is in post-fetal life because the mechanical loads are very different. The way that the fetus first forms its spine is very different from growth afterwards. And we know that the second that the menses starts, life is completely different. So I want to remind you that the spine looks like this, and there's lots of soft tissue around it, but we're going to really focus in on the bone. It is a very complicated tissue. It's structurally complicated, it's mechanically complicated, and it is biologically very complicated. So in order to deal with children's diseases, we need to understand this from the very basic science, from the genetics all the way through to growth and development, and how an intervention might alter that. I want to remind you, yes, I am a female engineer dean, and so I have to tell all of the male engineer deans and most of the male orthopedic surgeons that XX is not the same as XY, and that is a very different thing. Every single cell in the body has a sex, and as we've gotten to understand better, even for regenerative medicine strategies, this makes a difference. Female cells, even stem cells, do not grow the same as male stem cells. So this is now modifying how we go about regenerative medicine strategies across the globe. There are specific genetic traits that are expressed differently in males than they are in females that affect the quality of the bone quality. And there are definitely differences in muscle mass, and I don't think that's a surprise to anybody here. So we also have the problem of the menses and the differences in what happens at puberty between not just the genetic sex of the cell, but now the circulating hormonal involvement. And the signaling pathways are different, but we always have to remember that males and females both respond to all of these hormones. They just do it to a greater or lesser extent, in part because there's more or less of one hormone or the other circulating, but there's also differences in receptor numbers. But once the receptor grabs onto one of these hormones, the receptors function the same way. So with all of these problems, what can we do now? How can we address a spine problem this complicated when it just looks overwhelming? We can't even begin. And we're going to have to rethink how we're doing regenerative medicine, and that also applies not just to old people, but to children, because in children, this is the future for us. We want to make a solution, a device, a regenerative medicine strategy that will grow with the child. But before we even can get there, we have to understand the basic science of the tissues. We need to be able to understand if we change something, can we test it? Can we prove to FDA? Can we prove to the parents? Can we prove to ourselves that this is a technology worth doing? And we really don't have strategies that let us do that. So we can make structural things now. We can generate devices. These are actually templates that were made from trabecular bone from the femoral hip, and we can make them perfectly the same way time after time after time. And in cell culture, they work great, and in the body, they work great. But when we actually study what is going on and to trying to get them to work just perfectly, we discover that every human is different. And so oftentimes what you learn about from cell biology and your colleagues are telling you is true in cell biology has no bearing whatsoever on what's going to happen in the body when you finally have not only human variation, but you have differences in material design and the way the materials are functioning under load. So what do we do? What's the solution to all this? Because this is an overwhelming problem. So I'm going to talk to you a little bit about the way that we have gone through this, and actually this is our approach, and I'm going to talk to you a little bit about the Atlanta Pediatric Device Consortium in a second. But our approach has been to figure out what kinds of technologies are necessary to put in place so that when we make something that might ever actually work, we can prove to people that it might ever actually work. So we started with the problem that this is the standard x-rays that you guys look at. This is what an orthopedic surgeon looks at. And Mark assures me that when the orthopedic surgeon goes to do scoliosis surgery, he or she can't do it without you present. So because you've got internal organs that are going to be affected, and particularly in kids that are missing ribs where they may have lung insufficiency and many other problems that have come about. And you can't see very much there. What the orthopedic surgeon looks at, their practiced eye, they look at this and they say, oh, well, I'm going to straighten it. And when you ask them how they're going to straighten it, and Mark knows all of the people that participated in this technology, so I'm not going to name anybody, but what they do is they do it by feel. And I'm sure you understand that. A lot of this is by feel. But how can you plan? How can you show that to an FDA reviewer and say the same thing time after time after time that this is going to work out? So some very, very bright Georgia Tech students came in and developed an algorithm for taking ordinary x-rays, and I'm going to show you what kind of information we can get from them. They created this algorithm. They used standard low-intensity CT scans that came from Children's Healthcare of Atlanta. So you'll see in a second how many people were involved in this. They wrote an algorithm that allowed them to take those low-intensity scans and x-rays and turn them into a high-intensity 3D structure that now can be used for treatment planning and then afterwards for assessing whether the technology actually works. And the power of this is incredible because now FDA has a digitized three-dimensional image that doesn't rely on someone saying it felt right. They actually can see if it was right. So just walk you through, this is the reconstruction picture that you can get. This is from a low intensity X-ray. Look how beautiful that is. Now the power of that to a surgeon is amazing because they can do treatment planning and then we can do assessments. So we have to face the fact that in the current state of the art in surgical device development, we don't have really good ways of telling whether something is good or not good. We can do the kinds of studies that we've been hearing about here, and they're wonderful studies, but they are not powered sufficiently to let us come to really good conclusions. And this is a very complex process, and it is just driven by error because of the way that we have to do. Every patient is different from every other patient. But the automation really is going to be a powerful tool for us. So we've made these kinds of tools, and we have created a whole bank of them, which people can now take advantage of. And how do they take advantage of this? And this is the idea that the FDA came up with, and Congress supported, and by the way, your organization, the American Academy of Pediatrics, the American Academy of Orthopedic Surgeons, all went together, lobbied together, and got this legislation passed to create device consortia that provides services to people that want to make pediatric devices. There's now 5 official ones in the US, and ours used to be Georgia Tech, Emory, and Children's Healthcare of Atlanta, and it now includes the Medical College of Virginia and our School of Engineering. These are the partners that we have that are in the organization. This is the executive board, but I want to say to you that we rely heavily on our clinician advisors. Mark is a very active advisor with us. Bruce Rubin, who you may know, is another very active advisor. So our mission of the Atlantic Pediatric Device Consortium is to get devices to a place where they can be approved and used in children by creating an environment that inventors can come to from around the country, around the United States. We haven't yet had anyone come internationally, but there's no reason why they could not. And we will help them get their device ready for commercialization. These are the kinds of things that we do. I'm going to show you a little bit about how we do it. Now, I don't expect you to read this. What I do want you to see is the intensity of what we have brought together in one location to help these people, that inventors, small companies, and in some cases very big companies, take an idea all the way through to commercialization specifically for use in children. So all of these different participants, all these different capabilities are available. And we have a product development pathway, and a person can come into this pathway at any place along the path and start to participate in the commercialization process. And we make grants to entities outside our institutions to access in, so they don't have to use their own dollars to pay. We define a clinical problem. In this particular case, it was craniosynostosis. We come up with a solution. In this case, it was a hydrogel that holds the bones apart while over time to keep the resynostosis from happening too quickly. We created an animal model that let us test that. We created the algorithm that's very similar to the one I showed you for spine so that we could actually measure these things. And we were able to show, because our pediatric neurosurgeons and pediatric craniofacial plastic surgeons told us parents will not let high-intensity CTs happen for their kids. Repeated x-rays, not a good idea. So we had to come up with a method that would let us monitor how this was going on. And if you really want to know, you can read all this real quick, how we did that. And then we adapted that now to an ultrasound imaging method where we can put a small microsensor in a stocking cap. The little baby can crawl around this consortium. There is no way, even the lawyers, even the legal advice is available. So you can imagine how we feel that we've been very successful. These are the patents that came out of that work. Some are mine, some are not, some are other people's. It's all, and we've actually moved the technology forward, and now for the Smart Brace technology, you can now get this from Children's Healthcare of Atlanta. Patients can come in and access into this technology. It's already available for kids. So all of this costs money. There's no one source of money that's big enough, but the Atlantic Pediatric Device Consortium can help you put the package together. So I just now want you to also know that many kinds of devices can be handled this way. The kids' cart is for renal dialysis for kids. The otoscope is so that moms can diagnose or get an idea whether or not the children, their kids really have ear aches, or whether or not they really need to go see the doctor and the single mom has to really take off from work. Buzzy, amazing. This is just a little clever device that now is FDA approved for diagnosing, preventing nerve pain when kids are getting repeated injections, particularly diabetic kids. Smart brace, we've already talked about that. So I want to thank you on behalf of the Atlantic Pediatric Device Consortium. I'm willing to talk about any of the technologies that we have where it is at a place where I can talk about it. I certainly would be happy to talk with you about my own technologies that my group is responsible for. And I encourage you to take advantage of these 5 consortia around the country if you have a device design or a thought that you think you might want to develop that would improve the lives of kids. Thank you very much.
Well, thank you very much. It was very, very enlightening and very nice talk. What I wanted to ask you is it possible to do remote access kind of stuff, like if we are in another state, can we liaise with you regarding new device development? And what would it entail? How many visits? Can our engineering team come and work with you? How can we do this?
Oh, you're asking if I thought you were asking about the technology remote access, but you're asking about do you have to be physically in one of our places? Absolutely not. The Atlantic Pediatric Device Consortium has awarded grants to groups in Washington, D.C. and Cincinnati, I think, is the furthest thus far, but most of them are regional. These 5 consortia are around the country. One is in Michigan, one is in Boston, one is in the D.C. area, but amazingly enough, those clinicians in D.C. at Children's National Hospital, they cannot get money from that consortium. They have to get the money from one of these other consortia. And then, of course, ours, which is Mid-Atlantic, and I'm blanking on the last one, and it'll come. San Francisco, yeah, right.
Thank you.
Yeah. Anything else? You guys are all inventing? Okay, the only other thing is if you've already invented and you need advice on clinical studies, if you are looking to do multi-center clinical trials, one of the things that has come up frequently is the need for one IRB that you can go to and manage large multi-site trials, and we can help you with that as well. Thank you very much.
Thank you, Barbara, for that wonderful talk.